So today we're going to present this case about this complex patient. He's an 84-year-old gentleman with past medical history of coronary artery disease, with history of CABG, ischemic cardiomyopathy with EF of 35 to 40%. He presented to us with 6.2 infrarenal abdominal aortic aneurysm with a very complex anatomy, which I will show in the CT in a little bit. The problem is with this aneurysm, basically it arises immediately below the level of renal arteries. It extends just above the iliac bifurcations, and the patient also have occluded celiac and inferior mesenteric artery, and had severe bilateral renal artery stenosis of 90%. And to complex things more, his right renal artery was oriented caudally, and the left was oriented cranially. So we discussed this case with vascular surgeons who say that this patient, given his age, ischemic cardiomyopathy, and many other comorbidities, he was really high risk for surgical intervention. So a decision was made to do endovascular repair. He was actually also turned down by surgeons for endografting with fenestrated grafts in the past, so we ended up doing it ourselves. So here is the CT, and if you can appreciate here, you can see the angulation here. It's very tough angulation. You can see the aneurysm. These are the renal arteries here. You can see the aneurysm. These are the renal arteries again. You can see the aneurysm extending all the way to the renal arteries. And here you can appreciate on this image here how prominent is the superior mesenteric artery, because basically it's giving flow to all the areas that should be covered by the celiac and inferior mesenteric. And you can see the orientation of the renal arteries as well here in opposite directions. So given the opposite directions of the renal, obviously we needed to treat this with fenestrated graft. But given the opposite direction of these renal arteries, it is recommended then when the right renal artery is oriented this way, that you can do snorkel. So it's only reported once that a combination between snorkel and fenestrated graft is done. So we only saw it in a meeting, actually, abstract. So we discussed it with we discussed among ourselves and with the makers of the Cook fenestration, and we decided this was the best way to do it. So basically what we did, we first accessed the brachial artery, and we barked a Viaban balloon expandable stent from the brachial artery in the right renal artery, as you can see here. And then we advanced the fenestrated graft from the right common femoral artery, like that. Then we actually after that, we deployed the upper part of the fenestrated graft, as you can see, and we accessed the superior mesenteric artery and the left renal artery using a gillis sheet from the left groin, one by one. Basically, we access one, put a stiff wire, and then access the other one. This process here was, it shows in one picture here, this process actually accessing these two, this was the longest part of the procedures. This part took actually 1 hour to do. So after we barked these two stents, we barked 6x22 ICAST in the left renal artery and 8x29 millimeter VBX in the left renal artery. We moved for the next step. And that step, basically, we first deployed the right VBX from that we barked earlier from the right brachial artery, and at the same time, we both dilated the graft here with the reliant balloon. We got really good result there. And then subsequently, we deployed the two stents we barked in the SMA. Here you can see us deploying the SMA stent. And next, we deployed the left renal artery stent. After that step, it went back to be as any repair. So basically, we deployed the rest of the fenestrated graft and did both iliac limbs. And we got, this is the final images here. And you can see here, you can see the renal arteries, and you can see the SMA filling really well. So the main reason why I wanted to show this case that people think about these two strategies, using fenestrated grafts or shimmy strategies, as competing strategies, but in reality, you can combine these strategies in cases that require that, and this case is a good example of that. Thank you very much.
Again, another great case. You guys are really showing great cases here. I mean, my first question always has to do with the indication, right?
Yes.
We have an 84-year-old gentleman already with bilateral renal artery stenosis, basically living on a SMA, right? So,
Yeah.
Personally, I hate touching the SMA, and if I know it's the only vessel keeping his bowel alive, I hate it even more. What kind of discussions do you have to have with the patient? How do you assess?
Right.
How do you assess? Everyone says, "Oh, he's a good 84." How do you assess that? And tell me a little bit about that decision, because obviously we can do a lot of different things. When do we make the decision of this is the right thing to do in this particular patient?
So in this patient, we had so as I mentioned earlier, this patient was seeing. It's known that he had this aneurysm, and it's followed very closely. So this aneurysm grew from 5.5 to 6.2 within 3 months. So that growth was very, very, very concerning. So 5.5 is when he saw the surgeon and got turned down, and 6.2 when we say, like, let's look at it and see what's going on. So that growth is very concerning, that this aneurysm was going to rupture anytime soon. So obviously the patient and the problem with this as well is, you're getting the CT scan, you're going to ask for the fenestrated graft, which takes like 4 to 6 weeks to be done, right? So that's part of why it took longer probably to engage the other arteries, because it grew a little bit more. So we discussed it with the patient, explaining, hey, if we don't do anything, this is growing really fast, and there's very high chance you're going to die. But if we do this is very high-risk procedure. You may actually, if we occlude the SMA and we're not able to open it up, then you may die from bowel ischemia. And we were very clear with that. Because, yes, we knew, the right renal, we've got that. At least we have one renal artery protected. But the main problem was the SMA. And we were very clear with the patient that the mortality risk in this procedure is very high, but it is higher if we don't do anything.
So again, I think that discussion, that's a crucial part. That should be a crucial part of your documentation. And I think if we learn anything from TAVR meetings and structural heart, as we're dealing with these very older patients, justifying why you're doing these procedures, looking at with frailty. All these things are things that I think are translational. So.
Once again, a phenomenal case, an excellent presentation. I'm just curious, the AAA post-procedure follow-up is fairly straightforward. What's the imaging follow-up, or is there any imaging follow-up for all the other ICAS stents that you placed?
Right.
And medical therapy also. I just have to ask about the medications, antiplatelets.
Right. So this patient was placed on dual antiplatelets, and actually our plan was to keep the dual antiplatelets as long as we can. Follow-up, obviously we're doing the CT, but we were always prepared if the CT images were not good enough to do arterial Doppler for the renal arteries and visceral Doppler versus angiography if needed. This patient is followed up actually already 6 months now, and this CAT scan actually showed very good flow in all. The good thing about the SMA is really big, so it's very easy. If you don't see it on the CAT scan, you know it's not there. So renal arteries filled really well, but we were thinking about renal Doppler if we needed to. Yeah.
Great. Well, great case. Thank you very much.
Thank you very much.
To keep us, please.